Welcome to the Transcend Health Solutions podcast, your go-to source for insightful discussions on ketamine-assisted psychotherapy and all things mental health. Join us as we explore innovative treatments, share expert interviews, and offer practical tips to help you navigate your mental health journey. Tune in and discover how you can transcend the challenges and embrace a healthier, happier life.
All right, so hello, welcome to the Transcend Health Solutions podcast. I'm Will Ratliff. I'm a nurse, paramedic, director of operations of the clinic, and this is Anna Maurice, and she's a licensed professional counselor associate who's been doing ketamine-assisted psychotherapy for around a year, right?
Mm-hmm.
Yeah. Just did 100 sessions.
Yeah.
We totaled it up. So we've been very actively involved in the Texas Medical Board process where they are proposing rules to regulate ketamine therapy in Texas. This is a pretty big deal because ketamine and ketamine-assisted psychotherapy has essentially been the first wave of any form of psychedelic medicine to come about in any true sense, and really used heavily clinically. And so what regulations we set in place in any state, but particularly a large state like Texas, can radiate out to other states, as well as generalize to other standards of practice for other psychedelics that may come around in the future, like psilocybin and MDMA-assisted therapy. And some of those therapies are kind of potentially being fast-tracked right now as well. So we're in a very interesting place where we're having conversations about access, safety, efficacy, how to think about this treatment and psychedelic treatments in general from a medical model sense versus a more psychotherapeutic lens versus, kind of tried and true known concepts that have been discussed for a long time within the realm of psychedelic facilitation. So Annabelle and I have both talked in front of the board a couple times. Annabelle actually was the first person to talk in the first meeting because she was one of the only people who showed up in person
You always show
to
up.
that meeting and got grilled by the medical board about medical things, which was wild to watch them do that for some reason.
Yeah, which they knew I wasn't a medical person. That was
clear, and yet that did not stop
Yeah.
them from asking very specific medical questions. And one of the things that Annabelle kind of immediately responded to when they started asking these questions were the fact that we are a whole treatment team.
Mm-hmm.
And that seems to be one of the first things that is not very clear to the Texas Medical Board. Obviously, it's their job to speak to practices that relate to physicians. That's who they regulate. So these rules are set for, in my mind, probably the reason why they actually first came about was the practice of delivery of ketamine vials to patients' home for self-injection. And because the rule is a parenteral, which just means that anytime that we're using like a needle to administer the ketamine, so an intramuscular injection, subcutaneous injection, or an IV, it's focused on that administration route and regulating that. So physician focus and whether or not a needle is used is kind of like where their main talking points, kind of are formed around, as well as viewing it through mostly an anesthesia lens, because ketamine is in the class of anesthetics or can be used as an anesthetic.
So like sometimes you might go for like a procedure and they're like the anesthesiologist is doing ketamine. Is that like correct?
Doing
or like they're administering ketamine.
Sometimes there have been some
they
cases.
are on ketamine. Well, no, I feel like I am gonna ask you some of these questions, and because I'm learning this type of stuff along the way, even though I'm working in it, I'm not like always like, oh, sometimes like you're getting ketamine as when you're getting anesthesia.
So ketamine's use through medicine is so vast. I was actually just reading a paper where it was talking about, kind of very austere settings, like, surgeries underneath like a shade tree, and using ketamine injections for the general anesthesia for procedural sedation for things with no medical monitoring in
Whoa.
settings like out in the middle of a field, and so it was talking about
Like, are they trying to get people out in the field to do the surgeries, or they have to do a surgery emergency in a field?
yeah, so like let's imagine that an urgent surgery someone had appendicitis and they didn't have general anesthesia equipment or training or anybody around that could do that. The paper was looking at, can you just give whopping doses of ketamine to people to do these, simple procedures and things like that? And it was talking about the safety of doing this with no monitoring, and that's probably the most viable option and versus other anesthetics, right?
Mm-hmm.
And so, it's used all over the world. There's different protocols and procedures for all of these things used in different dose ranges. And so part of the challenge is that there are these statutes that have come out of like anesthesia groups or emergency medicine groups or otherwise that say things about how safe ketamine is, what the risks of side effects and issues, adverse events are. And we're really talking about a lot of different things. We're talking about everything from very, very low doses of ketamine for pain, or more of the mental health, kind of dosing ranges, which are still very low, or very, very high doses, like what we might use for either a procedure like that, where you're taking someone's tooth out or you're putting somebody's bone back in place, or actually used in, anesthesia alongside the other anesthetic agents, I'm sure there are ketamine only surgeries that occur, in kind of modern medicine, but they wouldn't be the most common thing that you see. So I'm not exactly sure what the most modern use case for those things are, but it would probably rare to see ketamine as a solo agent for surgery.
Okay.
In a modern, operating room.
Like where you have access to everything you want.
Yeah, I think actually the only time I've heard of ketamine only surgical options were like, I saw like, I think it was like a case series of like shoulder surgeries that were like done with ketamine only for people who were trying to avoid all opiates because of like opiate addiction issues. And so they kind of leaned heavily on ketamine sedation for, continued pain management after to reduce that post-surgical pain and not use opiates. And it was like, kind of a feasibility thing. So this is obviously not a very common practice, but in theory, you could give somebody so much ketamine you could do surgery on them. It would take a lot, so that's what's so interesting is actually it's incredibly uncommon to see ketamine used for pure surgery application. It's used in surgery a lot adjunctively, but just like as a pure solo agent. But it is used pretty commonly for the facilitation of intubation, which is where anesthesiologists use it a lot. So as an example, if someone had a really bad emergency situation and they needed to be, rushed back to the operating room for a surgery, there in the ER, it may not be uncommon for an emergency room physician to do what's called like a rapid sequence induction, where usually they administer a large dose of ketamine to render somebody unconscious for the facilitation of putting in a breathing tube or intubation, and then usually a paralytic medication on top of that to kind of paralyze all the respiratory muscles so they can pass that breathing tube with no issue, and to knock out the respirations so that those can be overridden with a ventilator, as well as reduce the risk for someone to aspirate their gastric contents during that process, because when someone comes in from a car wreck, they might have just eaten or something like that. So this kind of sedation and paralysis helps to minimize the risks of putting a breathing tube into somebody, and also the most humane way to do it, rendering somebody unconscious, for this process. You don't want to be awake during the passing of a breathing tube. That'd be a traumatic scenario. And so because ketamine has these use cases of potentially being used for like a procedure, it can render someone into these very dissociative states of consciousness, that we're using a lot of these rules that were developed for that setting for the low dose application of ketamine. And so a lot of physicians and a lot of medical providers and nurse practitioners and certified registered nurse anesthetists are kind of speaking to the Texas Medical Board and saying, the current rules and regulations that are proposed are a little too sweeping and more focused on the anesthesia setting and not the actual mental health treatment that is provided in so many clinics. And so the common dose range for ketamine-assisted psychotherapy or ketamine infusions usually in between a 0.5 milligram per kilogram and a full milligram per kilogram. And in that dose range, the risks are just much different than as you start to get above that dose range.
Mm-hmm.
And so that's what we've been kind of representing, is that we've had thousands and thousands of infusions. We've never seen any airway risks or medical risks of any kind. We've never had to call an ambulance. We've never, and we've seen people that have a lot of medical issues, that aren't necessarily healthy. I've even seen people who are, kind of hospice level, patients who did have terminal conditions and are, were not healthy. People have had past heart attacks, past strokes, seizure disorders. We've seen a full gamut of more complex patients at our clinic administering these low doses of ketamine, and the safety profile is just pretty extreme when it's infused slow and the doses are low enough. And so the initial petition that I gave to the Texas Medical Board was, that we should focus more heavily on the regulation of telehealth prescribing practices, because that's actually where we're seeing harms and where the greatest concerns for safe prescribing practices really are. And less focus on in-clinic administration, because right now it seems fairly evident that in the last 10 years there really hasn't been any case reports of a patient intubated in a ketamine clinic or had respiratory depression or maybe like had a heart attack or any kind of event that would have made it into the literature of any kind. But there's only very few too, but the very few events of patient harm that have happened from ketamine administration happen in people's homes. And so we've been trying to get them to not see this as anesthesia, but see this as a mental health treatment that requires a collaborative care model more than just a physician prescribing oftentimes therapy integration, and that this care can be delivered by nurses, and that nurse practitioners can be involved in this as well, particularly those that have psychiatric training, like a psych NP, and that all of these providers, as long as they have competency in these areas, can do this safely to minimize harms, but keep the access there, because the treatment is not covered by insurance yet, and may never be covered by insurance. So it's largely going to be people paying cash for the service. And so how do you deliver the service safely, where it'll also have high efficacy and kind of greatly reduce any chance for harm, why not elevating the cost through the roof to the point where no one could actually access it except for very wealthy people? And so, and generally speaking, the patient population that we tend to see are people with treatment-resistant mental health conditions that sometimes are out of work, or maybe on leave from work to do this treatment, or even just the treatment taking several hours and everything else. Like there might be reduction in how often they can be working during a treatment series. For a lot of reasons, we don't want to increase the cost to patients. And then, just the last thing on that is just that.
Well, especially if it's not resulting in better care or safer care, like just to have to increase the cost due to like an arbitrary rule that doesn't actually make things safer is ultimately so much more frustrating.
Yeah, I mean, there's a number of industries that have had to kind of look at this, in regards to, wouldn't it be amazing if, we we could, provide. I mean, you could get extreme with it. How about 2 physicians and 2 nurse practitioners and 2 therapists and
Yeah.
several nurses, and hell, why don't you put them on 3 cardiac monitors just in case one of
Yeah.
them goes south? I mean, you could get so ridiculous with the
Yeah.
level of care that we potentially could provide in the name of safety. You know, you could just continue this argument for forever. So it's such a strange situation that when we look at the actual real world risk and we look at what happens when we try to do regulations, we need to think about what is going to happen with the proposed rule set. And so this proposed rule set that they have on paper looks like it would increase safety pretty substantially. The main argument that so many people have had is about physician on site, right? So if a physician is physically in the office when patients are receiving ketamine treatment, the theory is if there was an emergency, that physician would be very equipped and able to respond to that emergency. And that's totally true. If there was an emergency, having a physician here versus not having a physician here greatly would, help to make sure that the nurses or nurse practitioners that are managing that patient have that level of insight and judgment to, fully handle that situation. And so that sounds great on paper, right? That, let's get a physician there. And I think that's been one of the most complex things to argue against is that will increase the session price to the patient by nearly double. And maybe even make it so where that the only way to access ketamine treatment for most people would be without a therapist. Like something would have to change. And so when you try to weigh out like what are the most essential components for this treatment to be safe, in my mind, in the 0.5 milligram to 1 milligram per kilogram dose range, psychological safety actually is a big highlight. That making sure that somebody is well supported, before, during, and after these sessions and in between them, that their intaking was good so that they don't have a condition that would be contraindicated for this, like unmanaged non-mood stabilized bipolar disorder, that they could have a risk for mania, that maybe they actually become more suicidal after a treatment, which oftentimes with just a little bit of processing, fully resolves. But it's not uncommon for people accessing ketamine treatment to not have any psychological support, and kind of go through this, just a purely medical model. And so,
which I have worked with people too who are like, I have done just an infusion before, but I feel like I needed someone there to help me process. So I feel like that's what's hard too, is like the patient isn't going to necessarily know what they need going into the treatment, right? But then some people have gone to these places where they don't have a therapist and they're like, I actually really needed a therapist too. So it's like very confusing as well to navigate on the patient side of like, what am I even getting with this treatment? What could it be like? And then here we're having someone sit with you and talk with you the entire time, after, before, during, after.
Yeah. The other thing too, like when I've talked with other ketamine clinic owners that don't provide any psychotherapy at their clinic and as an offering, whether they want to or not, but they just don't provide it. One of the biggest challenges that they tend to see at their clinics are the patients drop out early. So they'll come do one session and then they don't come back and they ghost the clinic. The turnover is pretty incredible at infusion-only clinics, and just because of the lack of support. And so this is one of those things, right? So if we're trying to have great outcomes, I mean, this happens, that someone will come and do one session with us and we find out, hey, maybe they weren't ready, or we should do more prep before we continue, or maybe just the timing isn't right in their life or whatever. But generally speaking, when we integrate the therapist, this entire preparatory process pretty much greatly decreases the chances this person is going to fall out early on in treatment, not finish treatment. So a huge aspect of having high efficacy is making it through the treatment, and so being supported so that somebody can go through any potential increase in distress before it falls is kind of critical to even have decent outcomes or to even offer the treatment at all. If a huge proportion of your patients are just falling out in their first or second session because of lack of support, Yeah, maybe it should be considered that you shouldn't be offering the treatment, when it's the majority of your patients aren't able to make it through the treatment. And if the majority of the patients that came to a dentist's office that got root canals got infections, I think we'd be looking into that, right? I think maybe this person shouldn't be offering root canals if nearly everybody's getting infections afterwards, or this isn't working out. They're all getting dry socket, whatever it may be. Certainly, if we're talking about like surgical outcomes, I mean, if more than half of the the surgeries that a certain surgeon was performing were on the wrong leg, we'd probably remove their ability to do this anymore. So you're seeing ketamine clinics that have outcomes so poor because of lack of therapy support that it starts to make you wonder whether they should be providing the service at all. And so this absence of psychotherapy isn't a minor detail that shouldn't be a heavy point of conversation. And then, so, we integrate physician on site, we may have to lose something that's so critical for the efficacy and psychological safety. And that's not part of the conversation. It's just medical safety, is the main concern that the Texas Medical Board has, which makes sense coming from their kind of more purely medical lens. And so that's a point of challenge. So what's good about the rule is we have parenteral home ketamine administration that nobody in the industry thought was a good idea except for the companies that are making money off of it. Kind of going away. That's fantastic. No regulation on telehealth prescribing practices, which to me, the big concerns there are high dose ketamine administration. There are companies that dose as high as 1,200 milligrams or more.
Which we're doing what for a session typically?
So, of course, one of the things we're talking about is oral ketamine administration, high dose like that. When oral ketamine is administered, the bioavailability is about a third. So you kind of, reduce the dose, to a third to get the IV equivalent, if you will. So point is, when we're giving IV ketamine, we're usually like a half milligram to a full milligram per kilogram. And so a lot of our patients are getting like 50 to 100 milligrams of ketamine, okay? And oral ketamine, you are seeing some companies actually administering doses as high as like 1,200 milligrams.
Okay, so if we thirded that, it would be like 400 IV.
Yeah, so they're giving doses 3 and 4 times as much as, higher than
but with
IV
no
clinics.
one around
No
them.
medical monitoring.
No heart rate stuff, no.
And so that's dangerous for a variety of reasons. One, that dose is so high that it can be kind of more fully dissociative. So if someone, as an example, during our sessions, what happens if someone throws up?
You're right there. I'm there talking to them. I'm hearing them.
Let me ask you another question. If someone was about to throw up, do you actually, what would probably happen? Do you think that they would actually just be unconscious and just choke in their own vomit?
Never.
Or do you think they would just throw up like any other person?
I think they would just throw up.
Yeah,
they're always conscious enough that they would still know where their hands are, where their lap is.
Yeah, the dose ranges for ketamine-assisted psychotherapy, someone can hold their own vomit bag and throw it up. We tell patients to fast prior to session so that they're in anything to throw up. But, let's say that somebody just wasn't able to abstain from that or didn't tell us or otherwise, and they actually do throw up during a session. These patients are not at a level of sedation where they would just, aspirate. They would just be able to just throw up in a trash can, very easily and follow commands to do so and not have any challenge there. So they're not at a risk for aspiration in any kind of way. None of these patients are so sedated, because if I was giving ketamine to the degree where someone was so sedated that they couldn't essentially handle if they threw up, you'd probably be pretty mad at me because you're like, dude, Will, back it down, because I'm trying to do therapy with this person.
Talk to them. Yeah.
And straight up, they're unconscious. Thanks for rendering the person I'm trying to do therapy with unconscious. So this isn't occurring. And so that's what we kept trying to explain to the Texas Medical Board is during ketamine-assisted psychotherapy, people are conversant the entire way through. Yeah. There's no aspiration risk because they're able to just, follow commands and, all of this. And that we don't see respiratory depression, that we don't see large changes of vital signs at all. I've spent so many hours looking at the vital signs of patients on ketamine, and you really don't see much of a change at all. In fact, if I see any change to a patient's oxygenation, usually it's an increase in oxygenation because people are usually like taking deep breaths during ketamine treatment, as they're kind of like, sinking into the experience and stuff like this. And ketamine's bronchodilatating. So I don't see decreases in oxygenation. I don't see respiratory depression. Patients actually breathing slower. Usually they actually breathe larger breaths during, while they're under the effects of ketamine. And then the little bits of heart rate and blood pressure increases that we tend to see, that's not even universal either. That's usually just because of the anxiety that patients can sometimes have when they're coming in to do tough therapy and have a ketamine experience, which, is kind of, there's a lot of unknowns associated with that, right? So the mind kind of runs wild with how's it going to be today? And, the body prepares and releases some adrenaline there. And so you can see little heart rate and blood pressure increases, but, the actual contribution from ketamine with that is just, we're splitting hairs. What percentage of that heart rate and blood pressure increase was actually from the chemical effects of ketamine versus the anxiety? I think it's overwhelmingly, just kind of the more psychological piece. Someone's just a little anxious. And so we see little increases in heart rate and blood pressure, but none of them are really that clinically significant. 5-10% increases. Like, somebody's heart rate and blood pressure would have increased more than that walking up the stairs to come here. And so, we're discussing the boogeyman of what if a patient stops breathing? What if a patient has, uncontrolled instability to their, vital signs that need to be managed by a physician level care? And what if they need, intubation? And I know where this comes from because I did do that work for a long time where I did give ketamine for procedures and ketamine to facilitate intubation. And yes, if you give a whopping IV push dose of ketamine to somebody very rapidly administered in a small amount of patients, that might slow their breathing for a little while. And I mean a small amount of patients. When I started working on the helicopter and I was trying to get used to, the speed of that environment, we're trying to have these like really quick scene times where, we're landing, we're hopping in the back of the ambulance, we're pushing some medications, we're dropping a breathing tube to somebody, we're doing some procedures, and we get the heck out of the ambulance, we throw them in a helicopter, we fly out of there, and we're trying to do this so quick. So sometimes when you're pushing ketamine in that setting and it's supposed to go over like a minute and a half, sometimes that turned into like 2 seconds. And so what I learned is, from early on and, that kind of setting was like, no matter how fast we're going, we still got to push our meds slow. Because those rapid boluses of most medications are not, not smart, whether we're talking about opiate medication or benzodiazepine or ketamine or any other. There's a huge difference between slamming a medication into somebody's system versus slowly infusing it over 40 minutes to an hour. And, so I guess my point is, from an anesthesia lens, when they've seen the consequences of what happens when you rapidly administer medications, they want to be prepared, for that situation. Like, look, you actually can see respiratory depression when it's bolused really fast. But we administer ketamine by an IV pump. And so there's no way in which that pump would ever...
I was going to say, yeah, we got the pump doing the work, not you
pump, even if I maxed out the settings, like tried to put it as fast as it possibly could, it still couldn't administer ketamine all that fast. It's a slow pump. So if I maxed it out 999, you know what I mean? Like, it's still going to just go not fast enough to cause respiratory depression. There's no way to make an error here, with the administration of ketamine. So it's very difficult for them to, kind of understand that, hey, this is a completely different indication, and at this dose range is a completely different safety profile. And there's been a lot of comparison to even other anesthetics like propofol. The case of Michael Jackson came up twice in these meetings, which, propofol is another anesthetic medication. So they're, they can all be used for surgery, but it has a completely different risk profile. Propofol does cause a lot more respiratory depression. It does cause a lot more hemodynamic instability. Its risks are completely different. And that was one of the conversations that happened at the Texas Medical Board. meeting was, what if we were talking about regulating propofol administration? Would everybody be like, oh, it's just a low dose? Well, that's just a completely different medication. So we would have to look at what were the real world risks of low dose propofol. And if we found out that they were in fact actually really, really low, then yes, we would create regulations that fit that low risk. And so it's been a lot of interesting, like cognitive things that I've seen going on, and with how they're like reasoning with these rules. So it's like, do we compare it to other medications? Like, do these apples to oranges comparisons to make these rules? Do we compare it to other dose ranges? And what everybody's been kind of asking for them is, kind of look at the real world risk. Like, this practice has been around for a while. The clinics are not having issues. The at-home providers are having issues. But we haven't done anything to regulate the at-home providers except for take away the parental administration at home, which no one in the industry even understood how that even ever came about in the conversation. That this was going to be something that people thought was a good idea. It's just wild. So those are the general things that we've been fighting against, trying to petition to protect the treatment, to have psychotherapists heavily integrated, to define that there's a difference in risk at the different dose ranges, that just because something's classed as anesthetic doesn't mean that we use anesthesia literature to impose the rules on this, and that we have to kind of look at what the actual impact is going to be, because it's of our opinion, and I've talked with patients, that if you all of a sudden double the cost of this treatment, people are not going to come to it. They're going to have to. Most people, if it was twice as expensive, just wouldn't be able to afford the treatment. They would have to do at-home ketamine treatment, which,
with no nurse, no therapist, unknown level of support,
with
unknown
no max dose, and what I've found is that most of the patients that I've talked to that got at-home ketamine, taking it as prescribed was not common. That it wasn't uncommon for patients to take 2 and 3 times the dose that they were prescribed, to take it either more or less often than prescribed, to have their friends and family try it just because they had extra.
Which none of that is possible when someone comes to our clinic.
No.
They never touch the actual ketamine except for through the IV.
Yeah, the nurse handles the administration, the monitoring of the vital signs and everything. And what I've also found is a lot of the telehealth companies, they'll like ship a patient like a wrist blood pressure cuff to like take their blood pressure, before. Doesn't seem to be any documentation of this, like to actually, I'm sure there's something in the paperwork that says, like, if it's above this, like, don't take the ketamine or whatever. But that's not what somebody's starting blood pressure is prior to ketamine administration. That's relevant, right? Because if it's already high, it's probably going to get high during, the ketamine administration, when it's actually
especially
in their
without
system.
someone there to help calm you or guide you through the experience.
But also, some patients have totally normal vital signs, and then during the middle of an infusion, they do have hypertension that does need IV medications to bring down a little bit, particularly those folks that already had kind of a history of hypertension, but their starting blood pressure was just fine. I've seen this so many times. So this kind of practice of like just taking a blood pressure prior to administering ketamine, I mean, it's better than nothing, but it's certainly not going to help all the cases, versus what we do, where we're like continuously monitoring the blood pressure the entire time through the infusion. The caretaker updates like every 30 seconds a new blood pressure. So if blood pressure is starting to rise, I'm seeing it happen in real time. I'm able to give incredibly small doses of blood pressure medication right then as it's starting to develop, to treat it, just kind of. And that's super rare. I mean, I don't know. When was the last time you saw me break out any labetalol? I don't know. You probably haven't seen it. I don't know. I can't even remember the last dose I gave. It's very rare. And usually when I do, it's a patient that I kind of saw coming from a mile away, that, they have hypertension. that their
different
hypertension
risk
isn't
profile.
totally controlled, that we kind of expected a little bit of hypertension, and so it's not like some big mystery that they might need some. And then usually we have them go to the primary care physician and say like, hey, look, your blood pressure's not really that controlled right now, like you might need just a general increase in your blood pressure meds before we even start treatment. So that's the more preferred way to kind of handle that. But either way, the protocols that at-home administration use, to me, the most concerning things are high dose and then too frequent of prescribing practices. So, because the addiction risk is also part of the conversation. We don't see addiction challenges in ketamine clinics because it's too cost prohibitive. Number one, someone, can't afford endless ketamine infusions. These things are pricey, so there's a limiter there. But we also, just as a protocol, will never do it more than once a week in an initial series. And then usually after someone has tapered out after an initial series, 30 to 90 days is like kind of a common cadence for ketamine maintenance treatments. So you will see some ketamine clinics, ketamine telehealth prescribers that actually have protocols for very frequent ketamine administration, for multiple times a week or even daily, which is just a really good recipe for starting to develop some dependence to it. And I have just never seen good data to support this for anything except for maybe some chronic pain conditions. But if someone's needing daily ketamine, the chances that inevitably causes a problem, over time, in regards to escalating dosages over time, increased dependency, there are probably just, I don't know, finding a patient that actually is the most, ethical and, just the most appropriate treatment option to actually administer ketamine every day in the mental health spectrum, it's hard to imagine. And so the idea that there's been companies that have been formed where every single one of their patients is on, a daily administration at any dose, because that's the thing. I mean, if someone starts out at a super low dose, I've never seen any data to say that that would be, a treatment protocol that we should be considering. It's just, daily ketamine administration. I've only seen things that relate to that potentially causing, addiction, dependency, and
yeah, because there's some people who go to the dentist and they feel great on the laughing gas, but we don't give them that every day. Or there's people who are getting addicted to that feeling and wanting that every day, and so it's just yes, it probably does make them feel good and relieve mental health symptoms, but are you actually then long term guiding them towards healing, support, getting away from what they're struggling with, or are you creating more problems for them to wrestle with now, having an addiction on top of that?
So what were I don't know, I know I talked for a little bit about the different things that I saw in the meetings and the logical fallacies and where a lot of the conversation is kind of hung up. You have a different perspective on this, right? You're seeing a bunch of medical people argue about medical things largely. What has this been like for you to sit back and watch?
Yeah, I feel like there's some part of it that does feel like there's some gatekeeping and what title and what role, because ultimately I'm all about who's competent enough to be in the positions that they need to allow safety and people to have access to this. When you were talking, it was making me think of an image where the risks when you're driving through neighborhood driving versus on the highway are completely different, right? But if you're making all the neighborhood rules based off highway crash data, that's completely well, yes, maybe someone was in a car and they crashed, but we have to look at the context of that, right? They were going 85 miles an hour on the tollway, right? Versus okay, I'm going 30 in the neighborhood. That's completely different. But to me, it feels like what they're saying with this rule is to go 30 miles an hour in the neighborhood, there needs to be 5 people in the car with you, and we need to be watching your every move, but go ahead and go 90 on the toll road by yourself. That's what it feels like to me. And I feel like that's where my frustration's coming from of if we were saying like driving is dangerous, no one should do it, well, okay, that's causing more issues, but like I at least can get on board with that. But why are we cracking down on the lowest risk version of this while we're leaving so many holes open? Part of that, I think, is people aren't understanding what's happening actually on the ground with the different types of treatment, right? Like what people are doing or getting access to from telehealth, what people are getting in the experience of a clinic with a therapist, in the experience of a clinic with just an infusion. Like that's not really common knowledge, and it's confusing even.
Yeah, and I mean, to their credit, it seems like they are trying to figure out what the issues in the industry are, and they have heard what they have heard. They haven't really ever visited a site, it doesn't appear.
Not a lot of curiosity.
There has not been a lot of
That's what I will say.
Just a lot of assumptions based on maybe like, you know, things that they've read online or something. Because one of the things that, you know, came up in the last meeting was somebody talking about how patients are always left alone during ketamine treatment, that there's never any medical or support of any kind. They're alone in the room, which in our model, we have a nurse and therapist with the patient the entire time. So we were there at the meeting and we're like, well, yeah, like we're overloaded with support, you know, in the room. No one would ever be left alone, you know, at our place. And so we were sitting there kind of representing like, actually, no, we always have, you know, one-on-one support from a medical side and one-on-one support from a therapy side at our clinic. And they're like, well, we're really trying to, you know, make rules for, you know, kind of everybody who's not doing stuff like that. And we're like, yes, and you're simultaneously shutting us down from the whole industry, you know, and only allowing, you know, for the most unsafe way to access this, the telehealth, you know, model to proliferate. And so it kind of reminds me of prohibition, you know, of alcohol, where it's like, you know, okay, we're seeing all these issues from alcohol. Let's, you know, try prohibition. Well, people make bathtub gin. People go blind from methanol. It doesn't decrease the access at all to alcohol, and you know, inevitably they decided, oh, prohibition didn't actually really help anything. It actually made things worse. And so in these sweeping regulations, it's like, okay, cool, this all sounds great. That definitely sounds like a protocol that would increase safety, you know, if you have heavy physician involvement. Meanwhile, there's areas of Texas that physician involvement isn't possible, that they need a remote medical direction.
Well, and simultaneously a shortage of physicians,
yeah,
and an acknowledged mental health crisis.
Oh yeah.
So while that's both happening, we're going to say to access this mental health treatment that is effective for people who are on the brink of removing themselves for psychological reasons, not because they can't breathe. Also, now you need to take a physician away from another hospital or being able to help the people that they would, just to have them sit on site, which they would have then been sitting on site for the past 6 years here and never have had to have actually really done anything.
Yeah, I mean, when I try to like logic this thing, I'm like, okay, what is the risk of this procedure? What is the risk of driving to the clinic? It's like 10 times more risk driving to the clinic than the procedure itself. And so you're like, well, if you're going to have any window of time where you would want a physician involvement, it would actually probably be on, you know, the Uber ride to and from the clinic. So maybe we should start requiring physicians, you know, come pick patients up at the house. That way, if they get a wreck on the way, then they'd be right there, because that's actually where the risk is. You know, and that's obviously ridiculous, right? And so, so I don't know. It's very difficult for me to wrap my head around. So then there's like the liability conversation, because it's like, well, there's no liability when a patient gets on the wreck on the way to a clinic, you know, in an Uber. So we don't really care about this window of time, even though there's 10 times greater risk in that window. That's not where we want the physician. The liability is when they're actually in the clinic, right? And so you start to see, you know, where medicine bends more to not where the real world risk is, but where is this going to like look bad, you know, if something happened. And so that being said, you know, I am well aware that there are ketamine clinics out there that don't have great safety procedures and will publicly talk about not only their safety, but how their model is just totally safe. And, they don't monitor patients. They don't have any medical monitoring on patients. I mean, you can go to the average ketamine clinic website and there will be a picture that's usually like, a representation of what their treatment looks like. And a lot of them will show someone not medically monitored, or not using an IV pump to do the administration, or, no one really around, that would be capable of helping in the event of an emergency, which the emergencies that we see from low-dose ketamine administration, if there was going to be anything, would probably be like somebody needs help throwing up into a bag, would be like one of the most common ones. If there was some hypertension, could it be managed? And if there was ever any respiratory depression of any kind, which would usually not be from the ketamine itself, but from ketamine plus other medications. So let's say somebody took a whole bunch of benzodiazepine medications before they came in because they're really anxious and they didn't tell us about it. Or they took more of their opiate than normal because they were having chronic pain issues that morning and didn't realize that that was an issue for treatment. And even if we asked a million questions, they didn't mention it, or whatever it may be. There's some other thing on board that we don't know about. And so they end up with respiratory depression, not because of really the ketamine, which doesn't largely cause respiratory depression, particularly in the dose ranges that we administer it, but that they had a lot of other stuff that was there, and then we added something on top. And so...
Which we're also doing a medical intake of each person to determine they're even a candidate.
Yeah.
So we are looking at, as the team that we are, right? Like, it's not just that they show up at day one and, oh my God, we had no idea that this was going to be a risk for you. We're talking about, like, for this specific person, what are the risks? What are the medications we need to be talking to them about? What does this look like for them individually? Which is just not necessarily happening to that level for even like telehealth or just at different clinics, which is part of what makes it unsafe. But that's like, we're being blocked from it as well, right? Even a clinic that is doing that talk with patients.
One of the other like things that comes up in my mind around this like conversation around rules and regs and everything like that is like, I didn't really know how old ketamine assisted psychotherapy was when we first started doing this. I actually found out after like a year of doing this that there were papers that dated back to like, early 1970s discussing ketamine in the dose ranges that we give it. They were talking about the safety of it in this dose ranges and its use for therapy. Like, I mean, this is not new. And so that's what's been so strange to me is ketamine is not new. Studies on its safety and efficacy are just like, God, if you go to PubMed and you just type in ketamine safety, it's just paper after paper. And, of just discussing it in every setting, whether we're talking about for dental procedures or for, any other kind of thing.
These are peer-reviewed research papers.
Yeah, a lot of them are pretty good. And, or discussing, when there are instances of harms, like what drove that. There's interesting case reports of like, there was like a hospital that ordered the wrong concentration of ketamine, and there was a slew of pediatric patients. I think it was like 9 of them that all got like very significantly overdosed on ketamine, and they just slept the ketamine off. Like they didn't have any long-term sequelae. There's like all of these case reports of, so anyway, you can take all of this information going back from the earliest days of ketamine use, speaking to even like, Vietnam era, administration practices and all around the world, and make a guess as to like, what are the actual real risks associated with this dose range. There's just so much information about low dose ketamine being safe. And it kind of felt like in these meetings, it was like, did they open up PubMed, or did they just go off of the experience they have, which is in the operating room? And if all you had is operating room experience, a lot of these regs make total sense, because there's always a physician in the operating room. Like all of these standards and things, they all sound great, from a very specific lens. But in the actual ketamine, in an actual ketamine clinic, we're optimized for the situation that is actually happening, which is that we're seeing the treatment-resistant patient population that are usually very highly distressed, and so the real things that we lean into and focus on in this treatment and try to make sure are, a heavy aspect of the process and the protocol for us is largely just the integration of therapy. And that's something I've been on the same soapbox about for 6 years. I always said, eventually, like I've been calling for regulation for so long. And I said, when it comes, it's going to be because of some harm that happened by a telehealth company. And then they're going to wipe out the in-clinics, the in-clinic care. I've been saying this for 6 years. And I've watched telehealth companies go on podcasts and everybody champions them. And it's like, oh my God, yes, we need to make ketamine so accessible. We have this mental health crisis. We need to, and these companies that are just like very loose with their prescribing practice and otherwise, kind of that move fast, break stuff kind of, like tech model, have just been celebrated for so long. And I've always been like, no, because like very early on, I saw patients that had issues with this. I had a patient very early on who was stabilized with their chronic pain after like, a series of sessions with us, and then went into maintenance. They're coming in every 30 days. They were seen at a very low price to make it feasible for the family, and they switched over to oral ketamine to make it cheaper. The difference was probably like $100 a month difference between the two.
With you now have no nurse, no therapist, no medical monitoring.
And I can't get into the specifics of the case, but this full model was really kind of what was needed. And so the loss of that, I took a hit to it. Well, and inevitably I ended up finding out that there was an aspiration that occurred at the home, and so that led to patient harm. And it was just kind of one of these things where the family called me and were like, it's okay to be vocal about this because this was awful, like we didn't know about this, thing. So point is that happened early on for us. And so I was like already off to the thing. And then we used to have patients that there was a prescriber that was like all up on Reddit, like that was just extremely active on Reddit and had prescribing rights in almost every state.
Damn.
And so people were just contacting this person for ketamine prescriptions like crazy. And everybody on Reddit was like, just go to this person, like no questions asked, basically, right? And, it was very evident from all those comments. That was like, just this kind of evangelical belief about like what ketamine can do and, all of this. And inevitably I saw that person, get inspected or kind of, stopped from, this practice, over time. And I always had mixed feelings on this because I'm like, I understand the argument that a lot of telehealth companies make where they're like, look, you can also go to a general practitioner and then 15 minutes into the interview, they, offer you a psych medication. They try to put you on an SSRI. Like how different is this really? Because those things have side effects and risks as well. And, sometimes patients become more suicidal on them. Sometimes they work fantastically for people, but, there are a full gamut of risks. And when you actually weigh the risk profile of, low doses of oral ketamine at patients' homes versus like some of the things that we commonly prescribe all the time, benzodiazepine medications or other medications can be addictive, opiates, etc. Like, is that the big, problem? And so it's a really complex conversation about like what is the best thing to optimize for, like just access, safety, like how do you create balance in this entire thing? And so in my mind, in clinic care is always going to be the best. I also well aware that there are areas where people can't drive 3 hours to go to a clinic at all. Like them being able to get ketamine delivered to their home might be the best option. So what you do there is you create a max dose limitation, and you create regulation around how often this patient can be prescribed, and all of this. That way you can at least kind of maximize safety in that setting. So do I think that at home administration needs to disappear? No, but I think that when you're prescribing somebody at home ketamine, if they like, this should be indicated. Like, this should be it should be very defensible, that how you document this thing. It's like, this person, it's not, they have a disability which they wouldn't be able to drive to the clinic. It just wouldn't be feasible for them in one way. There is no clinic near them, and therefore I felt like the best option for them was to prescribe them ketamine for their home. And I've explained to them what this can be like. They actually have someone who can support them. There is a viable 911 system in their area. Like, it checks all the boxes. I think this will be safe to send ketamine to this patient's home, and everything will go okay. As well as I kind of have enough of a patient relationship with them that I can trust that if I send this ketamine prescription to their home, that it's going to be taken as prescribed. And that would probably be pretty difficult to establish before most prescribers would feel comfortable. But that's not what you see with the vast majority of telehealth prescribers. And so anyway, I mean, the other crux of the issue is just no insurance coverage, right? Like, I don't think most ketamine clinics would be arguing against physician on site if insurance companies were just paying for all of this. They wouldn't care. They say, put 5 of them, over there. They can form a human pyramid of safety, that the patients walk through as they, come into the
like
clinic.
that tunnel after
Yeah,
a game.
that's what I'm imagining. Just like 10 physicians just lined up that you walk through as you enter the clinic.
You will be completely safe.
You couldn't actually be safer than
well,
this.
and like, not to mention, just briefly, like, from a therapist perspective, like, the things that I've witnessed from a therapy perspective that are possible with this treatment are like astronomical. Like, that, like, there is so much that is possible in terms of like walking in, hearing someone say just like, it's everybody else's fault, nothing can ever change, to like a couple sessions later being like, and I now see how I'm contributing to my own suffering. And just like, that typically takes a year, sometimes never happens with talk therapy, like, so the perspective switch that people can gain through this treatment to really start to get their own power back, and like, how, regardless of where I'm starting, like, how am I involved in my own life and my own suffering and my own pain? What are my options? Because ultimately it starts to feel like your only option is suicide or a life of misery. And how do we help people as quick as possible see that there's other options? This treatment is effective in that. And it's really hard to even explain that to other therapists because it happens so much faster. And sometimes what I'm actually guiding people through is the pain that can happen because they're changing so fast, and everyone else in their life isn't ready for this version of them, or isn't ready that they're completely different than them 2 weeks ago. And of course, everyone's on a different journey. Every pace looks completely different, but that's not the exception. To hear after like a few sessions, just a complete shift in their perspective, in their just like role that they have in their own life. And so to have that threatened, basically, when like that's so possible, and that could be the norm, and that could be the future in just so many different ways, is what's really mind-boggling to me, or just ultimately gets my ass to the TMB to be like, if there's any room for me to have a word, don't block this, at least in the capacity that I'm experiencing it. So
yeah, and I mean, just like some final points here, what I can say is, as a nurse, if I was told to give a patient 2, 3, 4 milligram per kilogram, of ketamine, even if they were very healthy, I'd be like, give me a doctor here. I'd really prefer to do this with a doctor right over there. In this kind of below a milligram per kilogram dose range, I'm like, sure, if they want to be over there, but like, there's never going to be anything that comes of it as long as we're, screening folks, for all the things that we need to be screening for. So maybe that physician would be better suited in an ER or an OR or somewhere else so they can be kind of maximizing their impact with their skill set versus just kind of sitting here waiting for an emergency event, because we have people who do that. They're called paramedics. They function on ambulances, and we call them and they respond. And in a city, they can be here pretty fast. We have an ambulance station like over there in our parking lot. We have all this emergency capability here, and it's like the odds of me even having the time to do anything in the event of an emergency before a paramedic is here is wild. And then there's an absence of mention of paramedics in the rule set. That Texas isn't necessarily friendly for paramedics working. It's so weird because it's like, oh, in the event of emergency, we're going to call the paramedics, but you couldn't staff a paramedic in the clinic in the event of emergency. That's got to be a physician or someone else. So it's like we're very comfortable with the idea that paramedics can respond to emergencies and can handle the types of things that would come up, from, a burst event from ketamine administration, but not confident enough on it to actually integrate them into the model to provide that safety, like in the clinic. Just so weird. Because in my mind, that would be the solution here, right? Like, what is a person who can have the competency to manage the emergencies that might astronomically come up from ketamine treatment, who their salary won't greatly increase the cost of the patient to the point where the treatment is now inaccessible. That person is a paramedic, but that's not in the rule set anyway, and there's almost no point in arguing about it because I don't know. So I don't know why it's like a hard belief that they can't work in. It's always so. I mean, I've experienced both settings, and that's the thing is like I used to administer ketamine to patients like in rolled cars, and every in a ditch in the middle of a field, with a broken femur, like in all these crazy uncontrolled settings in a helicopter, ambulance, whatever it may be. And then you're like, okay, so all that's good to go for a paramedic, but the stable setting with like good lighting and like that's actually like set up for this, that has all the right equipment geared for the exact things that might come up from ketamine, that's too strange. And so it's always been really strange to me that.
But also only for mental health. For chronic pain, it can still be administered, right, in pain clinics through an IV without a physician on site.
There was there was major ambiguity around what are we talking about, like that when it's for pain we have a completely different set of rules.
Which though to me doesn't make any sense, because if we're actually caring about someone's risk that their airway collapses.
Well, I mean, we need to integrate.
Could it happen if they're in pain physically or emotionally? Like, is there a difference?
I don't understand the aversion towards integrating dosing per administration route into the rule set, but that's actually what's needed, and that's what's been suggested so many times in these meetings. Is like, yes, all of these suggestions that are more relevant for a higher dose range, just make them required for a higher dose range.
Yeah.
That if you're giving doses of ketamine, that are very, very high for some indication like a specific chronic pain issue, yes, you're going to need a physician around for those levels because they're fully dissociative. There's a completely different risk profile, and these patients are sedated enough that they, can have aspiration, respiratory depression, etc. That's a physician level patient. And then, if someone's getting 0.5 of ketamine, I would never suggest this in any kind of way, but man, a lot of people on 0.5 of ketamine over an hour could answer their emails during. Like, it's just we're talking about really different things. And so don't answer emails on ketamine. Not even spam emails. But I'm just saying, I do believe if there was like a ketamine Olympics where we were actually like, doing like, could you answer this email on 0.5 over an hour? I think most people could probably physically make some form.
Can you sign your name?
Like, they could hit the reply button and at least smash their head on the keys enough to like send something off. I think something could happen, but but it's not sedating enough. It's just the dose just isn't high enough. So without the rules being tied to any kind of dose ranges, you know, it's going to be very hard to create a sweeping rule that actually increases safety that doesn't, because right now what we're actually looking at is people are going to die because of these rules. And that's wild to think of, that they're going to force clinic closures so people will lose access to care and either go access ketamine from the streets or go to telehealth companies, which is honestly not that much different than accessing it from the streets in a lot of ways, and be unsupported, not medically monitored, maybe have, you know, harms associated with not being monitored, or just not get treatment at all and complete suicide. And so, you know, there's going to be an unknown death toll from the rules as written. Now, the Texas Medical Board has been slowly relaxing around some of these topics that don't make that much sense. But what I didn't see is anybody on the board that actually like seemed to have popped up in PubMed and actually like read at least 10 studies prior to some of this talks. There's been people confused about whether we're talking about S-ketamine or whether we're talking about racemic ketamine. You know, they've loosely heard. I mean, we're talking about completely different medications sometimes in this conversation, just from confusion, not making comparisons or things like that. Just like, wait, what are we even talking about making rules for? I personally think if you don't know the difference between ketamine and racemic ketamine, you can't weigh in on a vote, you know, on ketamine. You got to at least be able to tell those two meds apart, you know. So I don't know. There was a lot of things like that where, you know, the kind of failure to recognize it as a mental health treatment with, you know, therapists actively involved, you know, what it actually looks like at most clinics, where the harms actually are. Because I said that, I testified and said, you know, like, look, I can't find a case report of anybody, you know, having harm in a ketamine clinic. And the response back was, yes, there's definitely been harms. As an example, this one patient who was given home ketamine, who inevitably had postpartum psychosis and, like, you know, hurt her family. And I was like, yes, I just said that there was not any harms at any ketamine clinics, that all of the harms have been at home that I can find in the case reports. And even the, you know, sensational.
Well, I think in that example too, it was like, well, I don't know if that happened at a clinic or at home. Like it wasn't like oh, it happened at home. That's why we're here to regulate clinics.
Yeah.
Like it was just I've heard this general story about ketamine and something bad happening.
So I don't know. I mean, I guess just to wrap the current, you know, situation for everybody where we're at, you know, they're going to review it again next month. Maybe rules will go into place, you know, at that time. And our hope is that any rules that go in place will create a more likely situation where people will still be able to access the best version of this treatment at a cost that, you know, isn't greatly inflated because of staffing structures that don't really help increase safety substantially, but only hypothetically. And, you know, kind of recognize this treatment as a mental health treatment and not like an anesthesia treatment or a purely medically focused treatment. Because I've always felt like it was just really funny that I've been like one of the most vocal proponents that therapy is critical in all of this. Sometimes I find myself like on LinkedIn arguing with therapists about this. Like, I'm like, why is it this? Why am I the one who is arguing therapists about how therapy is important? You know, it's very awkward at times, you know.
Somehow you manage.
Yeah. I'm like, I don't know why. I mean, because just from the beginning, that's what I saw. Because I did ketamine infusions where I was the nurse in the room where there was no therapist. And what I say about that is there is no such thing as a purely medical ketamine infusion. If you're in the room with a patient on ketamine, they're probably going to have things come up. They're probably going to talk to the person who is right there with them. And what I found is I'm just the therapist now. I'm just an untrained therapist over here having conversations with patients who are talking to me about things like suicidality, and I don't know what the heck to say or respond back. So I was like, look, this idea that there's like non-KP is hilarious. What actually
Mm-hmm.
happens is whoever's in the room is, whether it's
Becomes
a
the
paramedic,
therapist.
yes, they become the therapist, and they don't have the training, and they probably don't even know when they're messing up. I didn't know at all. I mean, I had situations where I'm like in a room with a patient who's on ketamine, who's going to see a therapist the next day or something like that, and I'm sitting there like messaging a therapist like, patient just said this. What do I say that won't hurt it anything? And like, what would be an appropriate response to this? And I'm just sitting here like, get in the room, man. Like, I need somebody in here who actually is trained to do this, because I can safely administer the ketamine all day, but it kind of seems like the point of this entire thing is what's coming up right now, and no one is around for this. And so it's sad to me that most patients who access ketamine are like alone on their couch, alone in a clinic, and they're not getting this therapy support. Because I've seen firsthand of what it looks like when you have an untrained person monitoring that, and they're trying to play therapist in these moments, or trying to figure out how to console somebody who's having a challenge, whatever it may be, when they don't have the training. And obviously, like, nurses are going to do their best and try to help, but are we going to advance someone's mental health in those moments? Are we actually going to be able to capture and make that a productive thing versus a potentially re-traumatizing thing? And I remember, just case example of this. I had this patient one time who was talking about how they came from a clinic where it was just like a medical, ketamine infusion situation. This patient had a lot of complex trauma, and he was having some things come up and had a big emotional reaction. And he said that somebody walked in the room and they were like, oh, he's having a lot of emotion come up. And it was really about being abandoned by a caregiver at a young age, that he was having emotion come up, and they were like, we better just like leave him alone with his feelings here, give him some space and privacy or whatever. It was extremely traumatizing, this guy.
Yeah.
He's like, I call out for help, and the response was like,
everyone
ditching
get
out of
away.
there, right? That they can't handle this emotional response, and that it's like too much for them or whatever. I'm sure these people are trying to help in that moment in the way that they thought made the most sense.
Like, I'd want to
give
be
him some
alone.
privacy.
Yeah.
But that was really traumatizing for this guy. And anyway, I guess my point is that we don't even. Those people probably walked away from that event thinking they had done the right thing and didn't even know the impact of what they had done in those moments were for that person. But it meant so much to be supported when they had this thing come up again during ketamine assisted psychotherapy. So anyway, I don't know. The lack of psychological support is the prime concern, for my opinion, in the clinics, and what we need to be focused on when we're talking about like in clinic care is like appropriate intaking procedures, heavily integrating mental health professionals in the mental health treatment, and then having sure, let's make sure we're monitoring, let's make sure that people are never left alone on ketamine, let's make some general regs around safe administration in clinic. The main thing that you could do is a max dose limitation. Just say don't go above mg per kg, or a too short of an infusion, and no bolusing of ketamine. That would overwhelmingly handle all the safety concerns that you'd ever have with just a dose limitation. And then the same thing for at-home prescription, that there needs to be a defensible rationale for why it was prescribed at home. This person's in a rural setting or whatever. There's a reason why you didn't just have them go to a clinic, not just because we can sell it, so we will. And then other prescription things that it fits the standard of care, that it's not prescribed too often or at too high a dose to be safe. And that would largely be the regulation that we need. But I knew that when regulation finally came down the pipeline, it was going to be all the wrong things, and that the actual real world impact would be more negative than if they hadn't regulated it at all. But I hope that we can make progress explaining some of these points, and we're going to try the best that we can. And even if some regs go in, that doesn't mean it's all over. We can continue to fight for what is going to preserve safe access, and not accelerate challenges. And so because just kind of what I was saying in the beginning, the groundwork that we're laying around the ketamine industry is going to radiate out to psilocybin and MDMA and just every other modality. And we don't want telehealth companies sending MDMA for daily use at high doses to patients' homes. We don't. That would never occur. That's what's funny, is that would never happen. They'd shut that down. The DA would come in 24 hours and shut that down. But we see that with ketamine. It's just which the reason why I hate that bringing that up is like a lot of these apples to oranges, like, you know, comparisons don't really work out, but you know, that's an example of like, you know, where this can be, right? And so I hope that these regs actually like get changed and they, you know, become a positive thing, that we're really happy with the regulations, because of the handful of clinics out there that, I mean, I'll just be honest, I know the dirt on like everybody in the area, and there's very small amount of people that actually really have problems. I mean, it's just a few places that, you know, really need you know, kind of increased regulatory focus. And so it's not a sweeping thing, and it's actually very, very targeted of some clinics that need some focus. So versus just, you know, trying to make one rule set that will shut it all, you know, shut all the bad actors out. No, it's going to be audits and very specific focus on, you know, actual problem places, you know, that we need. But anyway, any last thoughts on that, Annabelle?
I think just it is difficult to have to go up against this, but also reinforces like how important it is to have our voice, to be able to get to say something before a rule gets changed. But it's definitely tough to manage the internal rage at the injustice, because it does feel like kind of as we're leaving a gaping wide hole that we're kind of closing in on what is safe. So
all right, that's the
fight
pod.
for justice.
We'll do an update after it's all said and done. Till we meet again.